Guten Abend, bonjour, bienvenue. It's my big pleasure to announce Professor Frederic Ris from University Geneva Hospital. He's a visceral surgeon with a special interest in colorectal surgery. He's a specialist in rectal surgery and masters all these new techniques which are fascinating and which provide great benefit and improve quality of life to our patients. Fred, c'est un grand plaisir de t'avoir avec nous. I think the talk will be in English, so I pass the word over to Professor Ris. Thanks very much for joining us on this webinar. Thanks to all the participants, and the word is yours.
Thank you very much. Thank you very much for the invitation, and it's a pleasure. Ich kann ein bisschen Deutsch reden, aber das kann ich nicht mehr meine Präsentation auf Deutsch machen. Deswegen werde ich das auf Englisch machen. Ich verliere niemand. I will speak about transanal resection, and I think it's a great pleasure to discuss and to be with you tonight. So when we discuss about transanal resection, we need to think, why do we do transanal surgery, and in terms of cancer, and what can we achieve with that? We have to answer a couple of questions because it's less invasive, because we have a better staging, so we can do that. We have new strategies on the treatment, and as oncologists, you know that, and there is new technique, and I will just try to walk you through all that. So why is it less invasive? Because usually when we treat about rectal cancer, we do total mesorectal excision, and that's a big surgery, and we remove the rectum, and the patient has symptoms on that. So total mesorectal excision is a good surgery, is good for cancer, but we need as well to consider transanal resection because it's possible in some cases. However, it's not as heavy as a radical surgery. But when you look at different type of results, you have with radical surgery mortality, you have local recurrences, and you have a lot of bowel or bladder dysfunction, and a lot of people doing well as well. Especially here, we was look for T1 and T2 rectal cancer. If you look for just transanal resection, you see that the mortality is much lower, and that the local recurrence is a little bit higher, but that a lot of people do well, and maybe there is a way to go as well when you look at that. Then what are the morbidity and the problem with radical surgery? You get mortality, anastomotic leak, wound infection, bladder infection, chest infection, anorectal and bladder sexual trouble, and stoma. And then the nice old lady maybe doesn't want to go for that big things, and she wants to live even a little bit longer, but with no impairment of her function. So the advantage of the transanal resection is basically that it has a low morbidity, no stoma, good functional result, and a good quality of life. So we need to define when it is possible. That comes to the second question. Have we a better staging? And I think, yes, we have it. We can see with the staging we have now what lies under the iceberg and what is under the tip of the water. We have good clinical examination and under rectal ultrasound, and that help us to see around the tumor if the tumor is spreading or not. But if it's not enough, we always can do a good endoscopic evaluation. And now with a new way to see that, we see that there is chromoendoscopy with a good accuracy, but with a magnifying endoscopy with staining, we can increase the accuracy to 94%, and with the narrowband imaging as well. So we can have a good idea if it's a cancer or not, and if we can go further. but it's probably not enough. That's why we do as well MRI. And if you look here, you see a good tumor that is 3 centimeters wide, but we have no idea. And with the endorectal ultrasound, we don't see any lymph node around. And then the MRI will give us good information. And then we will see under the level of the water, and we will be able to see if there is something that will threaten our patient under the water. And that's very interesting. And that will allow us to say those patients are good for local excision, or those patients are not good for local excision because they need to have something more, and they maybe need to have radical excision or a new treatment. New strategies. You're probably all aware that there is a lot of new strategies. I won't wander among all of them, but we see that with a new strategy, you have, for example, the GREC-R2 trial that was published in 2017 and 2020. And basically, when you have a low T2, T3 cancer, no matter what happened with lymph nodes, you give them chemoradiotherapy. If they have a poor response, they go to surgery. If they have a good response with a scar that is less than 2 centimeters, they are randomized between radical surgery or local excision. And in those patients with a PT0, T1, they have a follow-up and they can be preserved. And there is an 82.7% of organ sparing strategy in those arms. So if you select well your patient, you can do local excision, and that has a place to take. I will speak about as well on the new comer, for example, the OPERA trial, which is basically to give normal chemoradio and a boost, or a chemoradio with a boost and a papillon. And so that will help us to give a better vision. And then in the patient with a complete response, we will have a watch and wait. If they have a partial response, they will have a transanal resection. And if they have no response, they will have a surgery. And that will basically, the papillon is to deliver with the beam directly on the tumor of the small tumor, on the lower tumor. They will deliver an extra boost of radiation that will help to have a better response on the tumor and has few penetrance inside the tissue, but just on the level of the tumor, that helps. You see that here on the OPERA trial, there was a follow-up at 14, 20, and 24 weeks. And here you have a very good response. You have a partial response with a small remaining area that is just ulcerous, and that maybe doesn't need to have a radical surgery. And you have a bad response with no response at all, and that probably need to do that. And if you have a good response with a good follow-up, you can have a closer follow-up as with a watch and wait procedure. And looking at that, it was really crazy to see that for small tumor, less than 3 centimeters, and with a good response, you have a very good overall survival. And that's very impressive. And that means as well that there is a spot in those patients to have a local excision if they don't have a complete response, because we have something to do with that. Not speaking about the total neoadjuvant therapy coming now on the market with the Rapido and the Prodige, and more recently the OPERA trial, where the complete clinical response can go up to 30%, even more. And in the OPERA trial, it was going up to 50% of conservative therapy and watch and wait. So I think now we're moving on to radical surgery for everyone. And I think from that, it's possible that we can get some of those patients who doesn't have a complete response, but a partial response, that maybe will benefit for less radical surgery. And that's the result of that. So that's all the organ preservation strategies that are currently on the market, and we don't have result for every one of that, but OPERA trial has been just published. The GRECAR 12 is on its way. The OPERA has been recently published with the brachytherapy, and there is different watch and wait strategy. So I think there is really something happening, without speaking of the immunotherapy arm, where we have the Garcia-Aquila paper with 100% of response for MSI-high patients, and maybe those who will recur will benefit for not having a radical surgery, but maybe a partial resection. So that's where we are and what we can expect. And then we can go to new techniques. And new techniques, that's the transanal surgery that has been performed in the past with the PAX anal dilatator. And then you go and you make the resection. And that's the classical one. You can do a parachute technique or a tracting flap. And that's okay, but you have a limited distance where you can operate, a limited exposure, and a limited quality of the specimen. So not everyone wants to have that in his bum. So we can go to transanal excision with a concept of the TEM, and that's a concept where you put a big tube into the bottom to be able to go with small instruments. And that has been developed by Gerard Boes in Tübingen, and he was probably very early there, and maybe too early that we take him seriously and that everything could spread, but that was a very good idea. And he published the difference between the TEM and the usual, and you have a better clear margin, a better way of having non-fragmented specimen, and a lower recurrence rate. So basically, it has a better way to operate on that, and that has been reported by others between standard resection or local excision with a good number of patients. And you see that for the morbidity, for the complication, for everything, even for the length of stay, is better if you do the local excision compared to the standard resection. This related in an increasing number of patients having that. So what happened then is that you have a benefit of the TEM, you have a better visualization, you can have a stable pneumorectum, but it's not always easy, and you can access to mid and upper rectum. However, it's quite cumbersome to have that in the bottom, and the kit is difficult to use, and as you see, there is special instrument. So what happened is that in the coming years, after teaching all of that, there was a new technique. So the slow uptake, because it was pre-internet time, we know that it happened. The cost was high, the learning curve was difficult, and the setup was complex. So what happened that there was a new kit coming out according to the single port surgery. And then we could do single port surgery in the abdomen, and we are thinking we can probably do it in the bottom as well. And that will help us to use our regular instrument to put it in the bottom and help have the light where it doesn't shine. And we were able then to do more surgery. We can even develop some glove port surgery, where we were putting a glove instead of a single port because it was relatively cheaper, and that helped us as well to access the rectum in a much better way. And that was an early experience in Oxford. But what is good that we can use the TAMIS gel point, and that's what we can do. We use a normal hook that we use for surgery, and we will mark all around the tumor and see to have the clear margin. And as you can see here, we have a good view. We get a very stable pneumorectum, and we're able to do that kind of surgery in a nice way. Then, depending if you want to go full thickness or partial thickness, you can inject all around to preserve the muscle layer. or you can decide that you don't want to preserve the muscle layer and go full thickness. Here, it's really look like a benign disease, and probably even there is a little bit of carcinoma, you probably have a way to do that. So I move on a little bit, and then you can see that elevating that, you can do the surgery in a very nice way, preserving the deep nerves, the deep muscle, and helping to do all the way around to lift the tumor and preserving all the deep layer. But you have the submucosa that helps you to make the good staging of what's going on. And you carry on all the way around, and you're able to remove quite big chunk of tumor in, I think, a quicker way than what we do that do the gastroenterologists, but I think we are in a close competition for that. And here you see, we can lift everything. You can go on some part on full thickness, or you can just have the muscle layer preserved, and that helps you to have all that. And that the surgeon can deliver in about an hour a good resection. That gives the specimen here that you can see that you will indicate what is the top, what is the bottom, what is the side, and that you can have the staging according to that. And then it was a PT2 LV negative with a budding grade A R0. And probably the patient is cured with that if you have no lymph nodes involved. So you can do as well with the gastroenterologist or the gastroenterology. So like here, when you do with an endoscope, in Switzerland, we're not allowed as a surgeon to do that with that way. So we don't use that kind of things, but you can see here in the different movie the way that you can observe, and you can try to resect big chunk of polyps. It's possible as well to do it robotic, but nowadays not yet very good, because you have a more stable platform and you have less instrument clashing. And that was the advantage, but it's like to operate through the top of a bottle. So at the time we were thinking, can we do that with a robot? Put that in the bum of the patient, and we were not sure. So we moved to the Sunnyvale Da Vinci facility to try the new robot and to see if we could use it in the bum of patients. And then we discovered that it basically was possible. And as you can see, you have the advantage of the robot because you have more flexibility and you have a better vision with the 3D. So we decided that it was kind of possible. And then we tried to do it on the patient in a study and showed that it was possible, but it's not yet picked up with pretty good specimens. There is a new robot now, single port, that maybe help us to do it in a better way. And but yeah, as you can see, it's not yet there. So it's not allowed from the company, from the regulation point of view, to do it yet. But I think it will come sooner or later. So how to perform the TAMIS? As you can see, that you need to have a good platform, intraluminal and extraluminal. You should probably have something lower cost than the robot, and you need to have a right quality resection for the neoplasm. And then we can use our instrument, and that's something good. So installation of the patient basically is as you can see here, we dilate the anus and we put the gel port inside, and then we can see very well from the inside. And in a male or a female, we can do that, and then we can start to do the surgery with a pneumorectum. That's the port arrangement that we can do as we wish, and we try to make some triangulation. And we use a stable platform for insufflation. The air seal is a very good one, but there is new one coming on the market that are good as well. is so good that the gastroenterologist wanted to compare with us, and I don't have yet the result of the Triassic study, but that will be the TAMIS versus the ESD, and we will see if there is a big difference, maybe in the time for resection. And yeah, basically. So when to consider for full thickness resection, probably we should not do it as a routine. As a surgeon, we were doing it as a routine before, but we don't want to have an impact of the radical surgical plan. And then that's why we develop as well the way to do it on the muscle layer. And then for patients more fragile or refusing radical surgery, that's probably a good thing. So if I summarize, the transanal excision is possible to perform as a macrobiopsy or curative approach with lower risk cancer in palliative situation, or after neoadjuvant therapy or organ preserving strategies when you have small remaining tissues that you're not sure of, and you could remove the full aspect of the remaining disease. You need to select well the case, and if you want to do it for a curative approach, you probably need to be sure that it's not more than a T1. If the tumor is less than 3 centimeters of diameter, is good. You need to have a complete excision, and you need to be sure that there is no risk factor. And the risk factor are given by the deepness of the invasion on the submucosal layer, the Kikuchi classification. And as you can see, if you have a Kikuchi SM1 or 2 is not too big, but if it's a SM3, the risk is as for a T2, and the risk of lymph node invasion is higher and goes up to 35%, a T3 higher and T4 even higher. So the risk for SM1 and SM2 is low. If you have lymphovascular proliferation, is bad sign. As the lowest third of the rectum is not so good, and if you have low-grade differentiation is not too good. So if you have that, all that risk factor, you can do radical excision, but sometimes it's difficult, especially when you go on previous surgery. So you need to be aware of that, and that's why we developed the possibility to do a submucosal keeping part of the muscle intact. But if it works well and has good setting, you have free recurrences in those patients. That is not so good if the patient had bad sign. So I think we probably need to consider rectal resection, local rectal resection for patients having a safety net, and the possibility to do completion surgery if it shows sign of risk. And salvage surgery is possible when the patient is well followed, if we can have it before things happen. The palliative approach is good for the old lady, low morbidity and no stoma. So in palliative patients is sometimes good just for the symptoms to be better. And I come to my conclusion. So transanal resection is worth the trip in selected patients. There is different techniques that we can do. The standard open resection is probably worse in terms of complication and risk, and that should be reserved for distal tumor. The TAMIS resection gives an alternative in well-selected patients with suspicious polyp or early rectal cancer. And I think with the TAMIS platform, with a good training, you can do that. You need to select well the patient, and for invasive cancer, the completion surgery is possible. And so I thank you for your attention. And as you see, we can always move above and beyond. Thank you for your attention.
Yes, thanks very much. Thanks very much. Yeah, there's applause. I don't know if you hear that. Great talk, great techniques, great options. Are there any questions from probably the room? I think Daniel will take over for managing the local, do the local moderation, right?
Yeah, there's a question from Jan. Yeah, she's already on the microphone. So
first of all, I would be hesitant to get this Apollo 13 rocket in my butt, but no, I have a question. You showed this very nice example with this Tamis technique, and it seems to be very, very elegant because we all use laparoscopic tools and so on, and it's just another area how to put the trocars, but it's actually you can use what you are used to, and I think that's very elegant. So thank you for that. But your example was a T2 cancer, and then at the end you say don't do T2 cancers because lymph node metastasis is high. So was it just an incidence, or do you do T2 cancers locally? And if yes, which kind of T2 cases?
Yeah, I will tend to avoid to do T2 cancer if I know that they are T2 cancer. Then if, like in this patient, you have a T2 cancer with no risk, I will probably consider, if I'm sure that I have no lymph nodes that I saw as an MRI, I will consider watch and wait strategy, but I will always discuss in the MDT as you were discussing before, because those patients maybe will, you need to discuss with them. They will have a risk of a lymph node metastasis of about 30%. So they need to be aware of that. However, they take the risk of being cured by 70% or to be followed and having a 30% risk of lymph node metastasis. And if they have that, you can catch it and hopefully operate on them early enough. And that means I will do a 3 months follow-up for 2 years with MRI and direct examination every 3 months. And then if nothing happened, then I will enlarge to every 6 months. Or you can propose the patient to have radiochemo to try to sterilize any lymph nodes. So
my question, if you decide in such a case to wait, additional radiotherapy, radiochemotherapy would probably decrease the risk of recurrence.
Yeah, exactly. But I wouldn't go straight away for T2 in my practice. I will, if I find it, I will discuss that with the patient, what his representation and what he wants. However, it didn't look like a T2 at the aspect, so we were not too good. But it happened as well that I had T2 on the MRI and looking with a proctoscope and saying, I don't think it's a T2. We do the macrobiopsy and it was just a polyp. So we avoided the overstaging of the MRI. So it's something very sensitive, and I think the surgeon that do the procedure need to have some experience with that, and to decide if he trusts or not. I was sure that there was no lymph node, but I have sometimes upstaging of MRI. Don't know if there is a radiologist that want to comment on that in the room.
Okay, yeah, thank you very much. I was just having a question regarding the robot, you know, for TME, this is now quite widely used. There's, not widely used in Switzerland. There are not many experts doing it or have the caseload, but this is quite well. I mean, it's quite good if you have the access and the expertise. But for local excision, the robot, as you said, is not yet ready. Is my perception correct that for TME, the robot is a good idea if you have the expertise, and for local excision, it's not yet there.
Exactly, you have a good understanding. For TME, it works well, and I think there is even a recent paper published last September showing that it seems to have better results than laparoscopic surgery. So I think it's on the way to go to robotic surgery. At least it's not dangerous. For TEM, transanal excision, it was an attempt with the last platform. We didn't try with the new one. And I think even the single port, Da Vinci doesn't recognize it as an indication so far. So I think with miniaturization, a smaller device, it will maybe happen, but at the time it's not yet on that. And I must say that doing laparoscopic transanal surgery is quite not easy, but is okay. So with a smaller platform that we're using, not the big one that was developed by the German, it's okay, and you have good result and good way to do the surgery. So yeah, I think robotic is not ready to go through the bomb yet.
Hello, Fred. Merci beaucoup. Excellent, comme d'habitude. Just a question. You said once we are, everyone is agree it's a good candidate to maybe know, but you have some limitation in the dimension of the tumor or not?
So I think if you have a polyp and you're sure that's a polyp, you can do with very big polyps. I remove up to 8 centimeter hemicircumferential, and sometimes I struggle to stitch it together again, which is the most difficult part. But if it's a cancer, I won't go for a bigger cancer than 3 centimeter. And I think the future is probably going to the treated tumor with the TNT and all the process that we are now putting in place to avoid surgery. I think there is some patients that won't have a complete response, but will have a sufficient good response that will be amenable to local excision. And I think those patients will probably benefit not having a radical excision. So, and we don't know yet who those patients are, and that's what makes the difficulty now. Did I answer your question?
So you have actually technically the same limitation as I have with the papillon, with the dimension.
Yeah. So and the opera trial, I think, is a good one, because you see that doing the papillon on the small tumor, you have a very good response rate and survival of organ preservation. And maybe we can add a small local excision to some of those patients, and we will even improve that. So I think time for surgery is within the next 10 years will be interesting, but I think you have to do some functional surgery as well, I think.
And of course for the relapse, because those patients all follow up really closely. Then you discover the lesion when it's very small, and that's the time to do the local excisions.
Yeah, exactly.
You always have the organ preservation, and you take care of your patient in that way. Merci beaucoup. À bientôt.
Avec plaisir.
Just one question from my understanding. You know, we discussed before regarding the lymph node metastases, and it is important that if you have risk factors in T1 or even T2, you need to consider those that risk for lymph node metastases. Do you consider the risk for lymph node metastases is worse or better, a worse prognostic feature than the local recurrence? Because what we are doing currently is just we give all those organ preservation strategies, and then we screen with 3 monthly, as you said, to detect these local recurrences. Because all these patients, or most of these patients, had received radiochemotherapy, I assume that the lymph nodes are sterile and don't recur. So, and that, from my understanding, these local recurrences, they can now safely be dealt with. So that seems not to be such a problem when once you have installed those follow-ups, really. But if the recurrence comes deeper in the lymph nodes, is this worse? Or is there further a risk that these lymph nodes do further metastasize further up? And is this worse than having just a local recurrence on the surface compared to in the depth in the lymph nodes?
I think it's a very good question, and I think we don't know really what is going on. So we are dealing with risk, and we need to check with the patient which risk we assume to take, and which follow-up we can do that. And I think with the close follow-up and the MRI, we have a good idea of what's going on. And if the thing are not doing in the right direction, we should propose radical excision in those patients. But yeah, in a way, it's a very difficult topic, because we cannot be sure that everything is sterilized. We cannot be sure that it's only a superficial recurrence. And I think we cannot sure that the lymph nodes that are enlarged would be related to cancer. So we need to assume in a certain extent that there is a risk, and the risk that the patient agreed to take, and the risk that our part, the doctor, agreed to take with the patient. But if we do close follow-up, I'm convinced that we can catch the moment the things are not doing well, and we can even make a closer follow-up in those patients. But it's just imaging, and maybe in the future we will be better at doing that. The Gina Brown paper were good to identify suspicious lymph nodes, but after, for example, radiochemotherapy, we have no idea what happened with the lymph nodes and if they are diseased. So I think it's a very difficult topic. That's why we still need to carry on and build the knowledge and discuss together. I think the discussion, the multidisciplinary discussion is very important, because we see everything with a different eye, and we can assume a decision even if it's wrong, because we can catch if things go wrong, I think.
Yeah, it makes sense. It makes sense. So even if you have a local recurrence, then it's probably safer to make a TME than a local excision. So to my understanding, for the moment, because the teams and everybody needs to learn if that's still safe to do local. Yeah, Michael, sorry.
Yeah, joining what you said, or following up from what you said, I think most of our patients, I mean, we rely heavily on the MRI, but I think from what I hear, especially for the smallish tumors, now I mean, you convinced me that I think every patient should really be seen by a rectal surgeon and examined also by a rectal surgeon, because I mean, there is so many options that we might miss, especially, and I mean, yeah, and maybe especially in the elderly, where we tend to like avoid having too many exams. But I think especially the vulnerable group of patients should be seen and examined by a surgeon, and maybe everyone. What is your thought on that? So
I strongly believe in that. I think the surgeon need to be involved in the care. The HSM, the MHS as well, recognize watch and wait as a patient that is valuable for the follow-up and the recognition. And I think it makes sense, because it makes that we don't have to operate everyone to be a HSM center. We can see the patient. And here in Geneva, we try to see every patient, even if we don't operate, even if we do watch and wait, to be able to first catch if something happened, work together, and even give the option to the patient, because you got 86 years old patient with which are very fit, and 60 that are not, when you need to offer them the best possible choice according to what you see. So yeah, it makes sense that the surgeon see it and discuss with you.
Okay, great. I think, thank you very much. I think I don't have further questions. It would be great if we could have for our listeners here your talk and the slides, if you don't mind.
Yeah, no problem. I can send it to you.
That's very nice. Thank you very much. So I have nothing further to say. Perhaps, Michael, do you want to close?
Yes, thanks again. I think it was a fantastic presentation, really up to date, and giving the outlook for the single port robot. I think we are waiting for that and some other technology advances, and looking forward to hear you in 1 or 2 years again on that. Thanks also for this discussion from the audience in Zurich and everyone. And I wish you a happy evening and see you soon. Thanks very much, Professor Ris. Thanks very much, Fred. It's always a pleasure. C'est un grand plaisir de t'avoir avec nous. Merci beaucoup de partager ton expertise.
Thank you very much for the invitation, and see you soon.
Thank you. Bye-bye. Bye-bye.